What's up, y'all? Welcome back. In this video, we're going to be going over vent settings and modes. This is going to be a quick breakdown of all this stuff. There's a lot more videos out there, books out there going into a lot more detail, but this is just going to be a quick intro so that way you know your basic modes, you know what the vent is doing, you know what the patient's going to be getting, and we'll also talk about these different settings that you may or settings in the vent mode that are going to be changed based off what our ABG is and how we decide what that number is going to be. Okay, so the first mode that I want to talk about is the most common one, which is assist control. So with assist control, basically the rule is the vent will deliver breaths. It's going to give a set number of breaths, okay? The patient, though, can breathe over the vent. And when they do, they get the same quality of the breath. Okay, so we'll come back to this definition whenever we're talking about the two modes that are under assist control. So the first one is going to be the more common one, which is ACVC. So this is volume control. And in volume control, basically the settings are, you're going to get a specific FiO2, respiratory rate, tidal volume, and PEEP. So let's talk about tidal volume real quick. Tidal volume is the mLs of air you inhale, okay? So that's how much volume it's going to give of air. Okay, so we normally dose this around 6 to 8 mLs per kg ideal body weight. Okay. Now PEEP, this is your positive and expiratory pressure. So at the end of inhalation, this is how much pressure is still in your lungs. So the good thing about PEEP is that it's going to keep your alveoli open for gas exchange. Now, normally at my facility, we go from anywhere from a PEEP of 5 to 15 millimeters of mercury, but it can go up to 20. All right, the problem with PEEP is that if you go too high, then you're giving this patient too much pressure and they can develop barotrauma, which then puts them at risk for a pneumo and more issues. And whenever you give them too much tidal volume, they can develop volutrauma, which is basically you're giving them too much volume, okay? So you have assist control, volume control, and then you also have assist control, pressure control, ACPC, okay? So this is pressure control. All right, so with pressure control, you're going to be giving them certain FiO2, respiratory rate, PEEP, and PIP. So PIP is your peak inspiratory pressure. So when you take a deep breath in, lungs fill up, that pressure that you have at the end of inhaling, that is going to be your PIP. So normally this is going to be around 30. So the patients who get assist control, pressure control, this is going to be for your poor compliance patients, your poor lung compliance. When you have poor lung compliance, basically the lungs aren't as stretchy. So if you give them even a tidal volume that is normal, like 450, that may be causing too much pressure up in their lungs. So somebody with a really bad ARDS, they're going to have poor lung compliance. Think of like a really stiff lung, even just feeling, say you intubate me, my lungs are healthy right now. If you intubated me and you put my PIP at 30, maybe it's going to be, 800, whatever number. But then say you give it to somebody you intubate somebody and your PIP is 30 and their max volume that they would inhale is only 350. So basically you're giving them enough volume until they get to a certain pressure and then it stops. So that may be you're likely going to get lower volumes in people with poor compliance. The thing that you have to remember is that when their lungs get better, the volumes that they're going to be pulling are going to be much higher. So you should switch back to volume control so that way you don't develop volume trauma. Okay, so going back to assist control, what the overall vent will be giving the patient is it's giving the patient this set number of breaths with the same quality. So if you're in volume control, it's going to give you, say, a rate of 12 breaths a minute, and that tidal volume is going to be 450. That's a 50% FiO2 with a PEEP of 5. All of those breaths that it's set to give, it will, so say it was 12. For those 12 breaths, it's going to give you that. That's the minimum it's going to do. It's going to do that every time until you tell it to stop. Now, if the patient breathes over the vent, say they're at a rate of 12, but they're breathing 16, basically those 4 extra breaths get the same tidal volume, same PEEP, same FiO2. Okay, I'm editing or exporting another video, so that's what that is. But that's what that sound was. But yes, so same thing with pressure control. So it's going to give you the set breaths, but if you breathe over it, you're going to get the same quality. Okay, so this can be good and this can be bad, right? So if you think about somebody who's in assist control, volume control, say you have a rate of 12, but they're acidotic, so the patient is breathing over the vent to try and compensate, that's a good thing. But say then the patient's in a bunch of pain, they're anxious, and then they start breathing a rate of 50 breaths per minute, they're going to get that same volume, same PEEP, they're going to be at way higher risk for developing barotrauma, volume trauma, all that stuff. So it has its good things and its bad things. So that's why with mechanical ventilation, you got to get these people sedated when they're intubated. When they're trached, then you can typically they're trached. They require that ventilation for a little bit longer, but with the trach, you can give them less sedation, unless of course they need it to keep them calm on the vent. Okay, so that's assist control. The next mode I want to talk about is pressure control. Another common name for this is going to be your SBT mode or CPAP mode. Okay, so we use these interchangeably at my facility, but the technical name of it is pressure support. Okay, so pressure support, that's one name. CPAP, SBT. Okay, basically in this mode, the patient controls the rate and the tidal volume. So they're pulling however much air they want, however fast they want. Okay, so this is used for weaning. Okay, and we're going to talk more about vent weaning in another video. But the settings here are going to be an FiO2 and PEEP. So they are still getting PEEP on CPAP. You can put them in like a BiPAP mode and give them inspiratory, an IPAP and an EPAP. So inspiratory pressure and an expiratory pressure, which is pretty similar to your PEEP. But these are going to be your two basic ones if you're running in CPAP mode. So you have that continuous pressure of whatever your PEEP is, and then you have an FiO2. But if the patient wants to breathe 8 times a minute and pull tidal volumes of 600, they're going to do that. If they breathe a respiratory rate of 35 and their tidal volumes are 250, then they're going to do that. Our ventilators will kick them back into whatever mode they were in before. So if the patient becomes apneic or they're breathing too slow or too quickly over 35, then they'll kick them back into assist control mode, which they were likely in before. Okay, so yes, we use this for weaning. Another thing that we can change with pressure support is the flow. So basically how fast they're getting that breath. So some people, when they're in CPAP mode, they may be like, oh, I feel like I can't breathe. They're breathing through a straw, right? So maybe they just need to get that air faster. The thing with increasing your flow is that you're also going to increase your circuit pressure, and you'll likely get alarmed. So the RT would have to alter that. Okay, so that is pressure support mode. CPAP, SVT. The last mode I want to talk about is SIMV, which is synchronized intermittent mechanical ventilation. So basically with this, the vent is going to breathe for the patient. But anything they breathe over the vent is independent. So it's kind of like a mix between pressure support and assist control. So basically your settings are the same. So you have your FiO2, your PEEP, you have your respiratory rate, you have your PIP or your tidal volume, but anything above that, so say they come out and, because usually you're going to see these in your post-op patients. So they come out post-op and they're getting a specific FiO2, PEEP, respiratory rate, PIP, or tidal volume. So say that's a respiratory rate of 8. They got to wake up in order to breathe above 8, right? Because a respiratory rate of 8 is not compatible with life for very long. So basically, the patient will wake up, they'll have to breathe over the vent, etc. So the bad thing about SIMV is that those additional breaths, they're kind of fluctuating in how much volume they're pulling, etc. So that it's more difficult to tell. With assist control, you know every breath they're getting that same quality. Okay, so a breath, and it's going to be alarming. So that's why we use assist control more than SIMV, and we use pressure support or CPAP or SBT whenever we're weaning. Rather, with post-ops, anesthesiologists like to use SIMV a lot. So let's talk about these settings and how they affect stuff on our ABG, and how we would change settings, okay? So you have your PEEP, you have your FiO2, respiratory rate, and tidal volume. These are going to be the common settings that we're handing off in report that we deal with. All the other stuff, don't worry about it right now. There's lots of like loops and waveforms on the ventilator that are good to understand, but you have to know this first, I would say. So you get an ABG, and you have some numbers that you don't really like. Say you're not maxed out on your vent settings yet. Well, we can probably adjust that ABG. Now what you have to remember is that when you're looking at an ABG, it's either respiratory or metabolically driven. If it's metabolically driven, you need to figure out what that other issue is that's going on first, or know what it is, an idea of what it is, because you're going to ultimately need to fix that. If this is respiratory driven, then we're already there, right? We're on the vent. We're probably, maybe we got pneumonia, something like that we need to fix. But if it's metabolically driven and we don't know what's wrong, then we got to figure it out. So these two, PEEP and FiO2, will affect oxygenization. I can't spell even oxygen, but I just woke up, so, And these two are going to affect ventilation. Ventilation is the removal of CO2. Okay, CO2, this is O2, obviously. So if you want to remove CO2. You got to increase the respiratory rate and you got to increase the tidal volume. If you want to retain CO2, you got to decrease respiratory rate and you got to decrease tidal volume. If you want to increase O2, you can increase the FiO2 and or increase the PEEP. And if you want to decrease O2, then you got to either decrease FiO2 or you got to decrease the PEEP. Okay, so whenever you're looking at your gas, you're going to get your pH, our CO2, our O2, and our bicarb. And you're going to get a base excess and an O2 set as well. Okay, so whatever your pH is, this is going to be dependent off your CO2 and your bicarb. So if you're acidotic and you have a respiratory driven acidosis, meaning that your pH is low, your CO2 is high, then we need to remove CO2. So we're going to increase the respiratory rate and or increase the tidal volume. Again, we don't really mess with tidal volume too much because remember, we're doing volume, or we're doing lung protective ventilation, okay? All right, so we may not really mess with this that much, okay? Now, as far as O2, if the patient's hypoxic, right? So it doesn't matter what their pH or CO2 is right now. If their patient is hypoxic, then we either need to increase FiO2 or increase the PEEP, depending on what our main issue is, okay? If we have an ARDS, we know that this patient has most likely refractory hypoxia, and going up on FiO2 isn't going to help us leaps and bounds. So that's just a quick overview of what each of these things are going to do. So when you change them and how it'll affect your ABG. That is the end of this video. The last video in this series is on vent weaning. So you can go ahead and watch that. Let me know if you have any questions. I hope you enjoyed the video. Have a good rest of your day. Bye.